Good morning, everyone, and welcome to the first day of the fourth annual Rapid Evaluation in Healthcare Conference. I am Arne Wolters. I'm the head of the Improvement Analytics Unit at the Health Foundation. The Improvement Analytics Unit is a partnership between ourselves and NHS England, where we use rapid evaluation methods to understand the impact complex changes are having on the healthcare system. And we're organizing this event in partnership with a number of other organizations today. So I'd like to thank in particular the Nuffield Trust, who are partnering with organizing this event. We've also had a lot of input from colleagues from Brace and Reset. If you'd like to know more about any of these analytical teams, there's an About Us section on the event platform. So there's a link at the top of your screen that you could follow to find out a little bit more. In the next couple of days, we'll be exploring a couple of themes around NHS recovery and sustainability. In particular, today we're going to focus on the recovery part, and we're going to see what role digital technology and AI plays in NHS recovery. And Josh Keith, who will be leading a panel a little bit later, will discuss some of the challenges and opportunities that digital innovation brings when it comes to in health inequalities and service evaluation. We're also going to talk you through a number of recent examples of how evaluation is informing policy making, and we're also going to have some breakout groups where you guys can have a conversation about health inequality, etc. So the day is sort of broken up in a few sessions. First of all, a plenary, as I mentioned, that Josh will introduce. Then there'll be a breakout group for you to discuss health inequalities and how that impacts, particularly during the recovery from the pandemic. That'll be followed around 11 o'clock with a 10-minute comfort break. And then we go to our final session to go through some evaluation examples in a little bit more detail. In each session, you'll be able and encouraged to ask some questions to the speakers. You can use the question box that is underneath the live stream at any time. You can also interact with other delegates by using the chat room. You can click on the chat icon on the bottom right corner of your screen. If you would like to tweet about the event, there's a hashtag rapid evaluation that you can use. And also just to make you aware that everything throughout the conference is being recorded and will be available on demand in the coming days. I think that'll be all. I will introduce you very quickly to Josh Keith, who is a senior fellow at the Health Foundation, who will be introduced in the next session. So over to you, Josh.
Thanks. Good morning, everyone. So as Arne said, I'm Josh Keith. I'm a senior fellow in the data analytics team at the Health Foundation, and pleased to be chairing this panel discussion this morning. So we're starting off today with a discussion to explore the role of digital services and AI in healthcare to help speed up the recovery. So before the coronavirus pandemic, we'd already been witnessing an increased focus on the role of digital services and data-driven approaches such as artificial intelligence. At that time, big claims were being made about the potential contribution these technologies could make to the future of health and care, and making better use of digital data-driven innovations was a big part of government policy, heavily featured in the long-term plan published in 2019, which included expectations about the role of digital appointments, transforming primary care and outpatient services, for example. And we're also seeing really big investments from government in new technologies, including the £250 million investment in the NHS AI lab. Obviously, over the past 2 years, we've seen the rapid deployment of digital health solutions as part of the health and care system's response to the pressures of the pandemic. So from the rapid deployment of remote consultations in primary and secondary care, the use of pulse oximeters to help monitor patients with COVID at home, and to the central role that data has played in the prioritization of the rollout of the vaccine program. Data and digital data-driven technology has featured throughout. But while the pandemic is still ongoing, there's now an increasing focus on what comes next as the NHS looks towards the recovery and the significant pressures facing the system. So these pressures include addressing the elective care backlog, the waiting list now growing to around 6 million, and addressing widening health inequalities, which will be the feature of a discussion later on today. And that's why this morning we had to focus our discussion on the role of digital services and AI in healthcare to help speed up the recovery. 3 particular areas or questions we'd like to explore with our panel. the role of digital innovation generally in the NHS recovery, whether AI can help manage and reduce waiting lists, and crucially, given the topic of today's conference, how can evaluation support the adoption and spread of these digital innovations? So we're, as part of this session, we're going to hear 3 different perspectives on digital innovation in healthcare from our panelists. And our panelists this morning, I'm delighted are able to join us, are Dr. Emma Hughes, who's the evaluation lead for the AI in Health and Care Award at NHS England and Improvement, Dr. Janet Owen, who's the Senior Research Associate at the University of Cambridge, who will talk about Project Breathe, and Professor Elizabeth Sapi, who's Chair in Acute and Respiratory Medicine at the University of Birmingham and Director of Pioneer, which is the Health Data Research UK Health Data Hub in Acute Care. So we're going to start by hearing briefly from each of our panelists, who'll give introductions to some of the work that's most relevant to the discussions today. We'll then go straight to a panel discussion. So if you've got questions for the panel, please do put those in the question function. And if your question is if you'd like me to direct your question at a particular panelist, then please do indicate that so I can make sure to direct it to the right panelist. We'll take brief clarification questions after each presentation, but if there aren't any, we'll try and get through to the panel discussion as quickly as possible. So that's all from me. So to start us off, I'd like to hand over to Emma to tell us more about the role of evaluation, the AI in Health and Care Award.
Thank you so much, Josh. I'm just going to move us on to the correct slide. Okay, good morning, everyone. As Josh mentioned, I'm Emma Hughes. I lead on evaluation for the AI in Health and Care Award. And I'll just be talking to you this morning about what the AI Award is, giving you a couple of examples of AI technologies that we're supporting that can potentially help with recovery, elective recovery in the NHS. And then finally talk to you about our approach to evaluating these technologies as well. So firstly, what is the AI Award? The AI in Health and Care Award is a £140 million fund that is operationally run by the Accelerated Access Collaborative at NHS England and Improvement. It provides funding available across 4 years for multiple competition rounds. And it's a programme that's part of the £250 million NHS AI lab that Josh mentioned earlier. Our overarching aim is to establish the UK as the preeminent destination for developing, scaling and testing health and care AI. Underneath that overarching aim, we have 3 sub-aims. So we aim to fund leading AI innovators to develop their technologies in the UK. So that's really about establishing and supporting a pipeline of AI technologies. Secondly, we aim to build a world-class real-world AI testing environment in the UK, which is probably the most relevant aim for this conference. And then finally, we are looking to accelerate the adoption and spread of proven AI technologies across the NHS. So just in terms of the structure of the award, it's spread across 4 phases based on the maturity of the AI technology. So the first phase is really about establishing the feasibility and proof of concept around the AI algorithm. The second phase is about validating that proof of concept and developing the evidence necessary for regulatory approval for the product. So this will often involve retrospective validation of the AI technology on multiple clinical data sets. The third phase is the first real-world testing of the AI technology. So this is really the first prospective testing of the technology at one or more NHS or social care sites across the UK. And then finally, phase 4 is about multi-site adoption and testing and validation of these technologies through multi-site prospective studies. Finally, phase 5 is not fundable through the award, but that's the phase that comes after phase 4, which is really where the technologies have shown evidence of their benefits and associated costs and are being widely adopted and used across the system. Just in terms of what we've achieved so far, we've received over 1,000 applications across 3 rounds of the award now. We've awarded 2 rounds of technologies and are currently supporting 79 technologies across those 4 phases. We've committed over £95 million of our £140 million pot so far. And then relevant for this audience, we are probably the biggest systematic clinical evaluation program for AI technologies in the world. So we've committed £7.5 million to evaluating those phase 4 technologies specifically as they are deployed in real world health and care settings. So I just wanted to give you a couple of examples of technologies that we're supporting that can help with the elective care recovery and backlog. So one of the technologies is one of our phase 3 technologies, and it's from the company called Navigno. And it's their intelligent workforce systems technology, which is really a set of smart sensors and an app that enables the tracking of both people and beds in hospitals, and consequently the optimization and increase in efficiency of use of those assets. It's been termed the Uber for people. So that can hopefully increase efficiency within hospitals and thereby enable a reduction in waiting times and waiting lists. On the right-hand side, the example I wanted to give was a technology that has been developed by Deloitte, and that's the referral intelligence and triage automation AI technology. A bit of a mouthful, so we call it RITA. That technology is aimed at supporting the automated triage of referrals from GP practices to secondary care. And so it aims to release clinical administration time to do other things, and also aims to end up with more accurate triage of patient referrals as well. So as I mentioned, we specifically commission independent evaluations of our phase 4 technologies, and we expect those evaluations to cover 8 key domains, which are shown on the slide, so I won't read them out. But essentially, these are mixed methods, real-world evaluations of the technologies as they are deployed. And the aim of these evaluations are really to fill key evidence gaps to inform the onward adoption and spread of those technologies across the UK, and inform assessment by NICE and other bodies such as the UK National Screening Committee, if that's the relevant group that the technology would fall under. We also know that there aren't any agreed standards about how you do real-world evaluation of AI technologies. So we expect these evaluations to provide a bit of a model for the how-to around real-world AI evaluation, and we're really learning by doing. So that's at the end of my short introduction to the AI award and some of the technologies we're supporting and our approach to evaluation. So I'll hand back over to Josh now.
Thanks very much, Emma. Before we move on to Janet, there's just one clarification question from Jeremy Wyatt, who's asked, given the investment in the AI lab and the AI award, how many RCTs of the impact of AI in healthcare are being supported through this process, and are any of these full-scale multi-center RCTs?
Okay, how many are randomized controlled trials specifically? So I'm afraid I don't have the number off the top of my head, and actually that was something that I thought we could explore a little bit. What we're seeing is that randomized controlled trials are not necessarily that feasible for real-world evaluation of AI technologies. So actually, in many cases, in most cases for the phase 4 technologies anyway, we're supporting quasi-experimental studies rather than randomized controlled trials. But a number of our phase 3 technology evaluation projects are randomized controlled trials because they're that first real-world testing of the technology, if you like.
Great, thanks. As you say, maybe we could come back to that challenge as part of the panel discussion. So in the interest of time, thanks very much, Emma. I'm going to move on now to Janet's presentation. If you're there, Janet, great. Over to you.
Thank you very much, Josh. I'm going to talk about the AI award that we received this year. And it's using cystic fibrosis as an exemplar for how to use AI to improve the quality of care and the quality of life for people with CF. This is a multidisciplinary program that is being run from the University of Cambridge, from Papworth Hospital, but it includes NHS centres, CF centres in Scotland, Wales, England, and now also Northern Ireland. So it covers all the devolved nations. I just reminded people here of the questions that are present for this forum. And I've tried to address these questions through my presentation. Just as background, the cost of chronic pulmonary conditions in the UK is in the region of £4 billion per annum, and we're looking for ways to improve the treatments so that we can manage this better. So the question is, why CF? Everybody thinks it's a very rare disease that doesn't affect anybody. In many respects, it's almost the perfect exemplar for conditions for a chronic pulmonary condition. There are 10,000 people with CF in the UK, and the vast majority are adults because of the quality of care. It's a genetic condition, so people are born with the condition. Nowadays, it's diagnosed at the age of 3 months, and so people live with this condition for their entire lives. So we genuinely have patient experts. We have people who know the condition better than anyone else. It's a young, tech-savvy population, and it's rapidly increasing in terms of the burden on the healthcare system because the number of adults is going up. This is due to the improvements in quality of care. It's also a result of the new treatments that are coming through for cystic fibrosis. Before the new treatments came on board, the number of adults with CF was increasing by about 250 per annum. This is based on the UK CF registry data, and that's the equivalent of one new centre per year, which is unsustainable. With the new treatments coming on board, we expect that to accelerate. So the current standards of care are currently are very effective. They've actually, say, improved quality of life, but it creates a huge burden on all aspects of the healthcare, the patients, the healthcare providers and the healthcare payers. CF is managed exclusively through CF centres. GPs are not involved, and there are something like over 55 CF centres across the UK. Since the onset of the, so one of the features about the current standards of care is that CF is characterised as a chronic condition which is stable for periods of time, but then there are people with CF suffer acute exacerbations, and these can happen at any time. The way this is managed is through people attending the CF centre every 6 to 8 weeks, whether they are well or not. And this is effectively to establish when an exacerbation is happening and to treat that exacerbation. This in itself creates problems, and we developed a system to try to address this. So standards of care for cystic fibrosis have been in place for decades now, and there is resistance to change because it has been effective. But the situation now is changing so that patients are demanding that they don't attend the clinic. It's tedious for them to go up to the clinic knowing that they're well. They sit around in the clinic all day, and then they get told your lung function is okay, you go home. And quite often people lose a whole day. It costs money to travel, and it also exposes them to the risk of infection, because people with CF suffer from infection in the lungs, and hospital is probably the worst possible place for them to go. This has placed huge pressures on the healthcare delivery. Virtually all the adult centres in the UK are over numbers, and it is creating problems. We did a review of the patient population, the CF community, to ask them what they consider to be their primary research needs. And the overwhelming answer to it was research to reduce the burden of care. And we did this formally through the NIHR and the James Lind Alliance, and it was overwhelming the request that research focused on this. So some time ago we started to explore if we could use home-based digital services to avoid unnecessary routine outpatient appointments. So people who were stable, could we manage them at home and reserve the outpatient visits for those who needed to be seen? So our first study was a feasibility study where we issued Bluetooth devices that were connected to an app on the mobile, and people were asked to record their data on a daily basis, if possible. And the data they provided was lung function data, oximetry, weight, activity, and temperature. They also did a wellness score, a very simple wellness score, and we asked them to monitor their cough frequency. Only the patients were able to see the data from this feasibility study, but the results from it showed that the vast majority of people found it useful. We only about 5% of the patients stopped the process, stopped the monitoring, because they became anxious about their data. And so the vast majority, and the feedback we've had has been amazing from the point of view of people learning more about their own condition and learning some self-management. I think one of the major features about this is that it gives you trend data rather than what you would get in the clinic, which would be a single isolated measurement. And that trend data is actually very valuable. And we found that people on the although the clinics were not receiving the data, people, when they attended their outpatient appointment, took their phones with them and said, look, this is what's happened to me over the last 6 weeks, which was quite significant. So this is the study we did, and I've just put some results in here. This is the study where we also, with consent of the people with CF, we sent their results to the CF Centre. And what we wanted to do was start to see whether we could actually reduce the number of routine visits. And we were aiming only to reduce 1 routine visit out of 2. We actually achieved much more than this. And this is pre-pandemic, because the pandemic caused a little bit of havoc for us. But the data came through showing that there was actually a positive impact on lung function, and there was a reduction in the number of intravenous days of antibiotics. And on the right-hand side, I've shown one of our star patients, who's actually our PPI lead for the AI program. And the mobile phone shows the data that they receive. They can also track back and see trends themselves. And on the right-hand side is the physician's portal, which the nurses can see. What we did effectively was to ask if we could avoid routine visits. And the routine visits were, so what would happen is that the patients would have their normal outpatient appointment in their diary. A week before that outpatient appointment, they would be contacted by a triage nurse, a specialist CF centre nurse, who over the phone would discuss their data with both of them looking at the data at the same time. They would discuss their data. They would come to a conclusion as to whether an outpatient visit was needed or not. We did quite a detailed assessment of safety of this, and there was no increase in emergency admissions for people taking part in the study. And as I say, the overall improvements were good, and the feedback we had from people was phenomenal. There was this sense of empowerment. They were in control of their condition. And some of the people, particularly our star person, was able to actually understand their data much better, and they were able to maintain their health. This particular individual used to be admitted to hospital 3 times a year minimum for exacerbations. While she was monitoring herself, she didn't have a single admission to hospital, because she started to see what was causing the triggers, where things were going wrong, and she was able to intervene earlier and therefore potentially abort exacerbations, although that clearly has to be proven. So the first study and the new study pre-pandemic basically showed it was safe. We could reduce routine outpatient appointments. We the other thing, the comments from a lot of the doctors and the nurses, was that the clinical decision making was improved because that people were judging it on trend data rather than one clinic measurement. The avoiding outpatient appointments basically meant that the specialist multidisciplinary team could be employed to those who need it most. And I think this is important. I talked to one physician recently, and they said they'd seen 7 patients at their CF centre that morning. 5 of them they didn't need to see because they were fine. One of them they saw it was beginning to have an exacerbation, and they were able to treat relatively quickly. The other one, they said they needed to see 3 weeks earlier because they were really quite sick when they turned up. So we're moving forward from this to start to analyse the data by AI. This has been done in an anonymised fashion, and I'll show you some of the data that's coming through here. You can see that each individual measurement is very noisy. So we're measuring lung function and all the parameters. But what we've done is with supervised machine learning, we're able to convert the data, and we can actually identify a exacerbation beginning to happen up to 10 days before it actually happens. So now we're in the process. The AI award we have is basically to complete a randomized controlled trial where we're going to give to people with CF the algorithm output and establish whether it improves their healthcare. So this is just my final slide. We found that digital home monitoring is acceptable to the vast majority of adults. It improves home self-evaluation and empowers people with CF. We're developing the algorithm to create a breed score, which we will provide to people with CF. This will allow better management of the care team and possibly reduce the number of inpatient days for people with CF. Thank you.
Thanks very much, Janet. And there's a couple of questions in the chat which we'll come back to afterwards. But now I'm going to hand over to Liz Sapi, who's going to talk about her work at Pioneer. Over to you, Liz.
Thank you. I hope you can hear me okay. And I can move the slides. My connection's terrible in the hospital today, so forgive me. But my name's Liz Sapi. I'm a medical consultant working in acute medicine. So that's front door medicine of a large hospital in the West Midlands. And I'm a professor of the same at the University of Birmingham. And I wanted to talk to you about Pioneer, which is an HDR UK hub, which curates and then makes discoverable and accessible really diverse data on emergency presentations and admissions to hospital. So why is this important? Well, acute care is any unplanned healthcare episode, and it places an enormous strain on the NHS. There were 110 million urgent same-day patient contacts, and the numbers are rising year on year. So in 2019-2020, there were 25 million admissions to NHS hospitals. We know that there are known health inequalities around how people use emergency services, with some people being more reliant on them than using standard planned NHS care. And we also know that as the demand for acute services rises and there are more unplanned admissions to hospital, it has a huge impact on how the NHS delivers planned care, such as planned operations or therapies. Chronic disease in an aging population accounts for a huge proportion of the cases that we see coming through the hospital. And we know that although this is a huge burden on the NHS and for patients in terms of the long delays they experience, we also know that there's been little innovation in this field. And that's because acute care is really complicated. It involves patient journeys starting in the community, maybe visiting their GP, seeing an emergency healthcare practitioner in the community, calling an ambulance, flowing through hospital systems and out to the community again. So it's incredibly complex. And Pioneer was designed to try and provide some means of understanding this system through health data. So the aims of Pioneer are always to benefit patients. We want to improve the care we provide in the acute setting, to reduce the reliance that some people have on acute medicine by thinking of other ways to deliver care. And the background to this is that most care processes in acute services are not based on evidence. They tend to be based on consensus opinion. We tend to have a one-size-fits-all approach, and that doesn't work for people. And we also know that new systems are adopted really quickly, sometimes without any evidence of whether they're effective or not. So what does Pioneer do? Well, we're an ethically and CAG approved secure research database and analytical environment. We link patient data at an individual level across community, ambulance and hospital healthcare providers. The data is near real time, frequently refreshed, usually weekly. And we have a private cloud-based system using Microsoft Azure, which has been cybersecurity tested. And from this, we have the ability to build bespoke trusted research environments where researchers that want to innovate and improve healthcare can access data going through quite a robust but also very agile regulatory process. We have transparent public oversight to data sharing with something called our Data Trust Committee, which is a group of patients and public members that review every single request that comes in for data. They meet every 2 weeks, and if they don't think that the data request is in the public interest, we don't support it. And 80% of that group have to approve data access before data access is given. And we provide data access under license to NHS, academic, commercial, policy, and third sector organizations. And this slide gives you a rough idea of how we do it. So we take in data from primary care, ambulance, and secondary care settings, mainly based in the West Midlands, but we also have national representation. We bring that data together and make it accessible for the sole purpose of improving health and care for our nation. It's been used so far to improve biomarkers, look at different ways of diagnostics, treatments and pathways. We have responsible data sharing under license with public oversight, as I spoke about. And the whole purpose of this is to deliver advances. The kind of data Pioneer holds is vast. So it's much more than what you might find from hospital episode statistics data. It goes into significant granular detail, looking at every single physiological recording, every single acuity score, every single blood test that followed the admission, every single medication that was prescribed and administered, and all of the times between those processes as patients flow through the system. And through Pioneer, we also have ethical permissions to look at what happened to the patient before that acute care journey began, and afterwards to look at the long-term impacts of that health and that healthcare contact and what came from it. And the reason for doing that is that we can then identify what diagnostic opportunities were missed, what was the impact of diagnostic delay, and by bringing that wealth of data together, see how it can be best utilized to really transform care for our patients. And that's of huge importance for me, given the arena that I work in clinically and the lack of innovation that arena has seen. So what can we offer as a service? Well, there's data as a service, so people can apply to Pioneer to access data using this ethical and governance framework. But data alone isn't the answer. So we also can help with analytics. We have a fantastic patient and carer community that will come and help researchers understand what the priorities are for patients in terms of the questions that are being asked. There's clinical expertise as well by people like myself, but also from a diverse range of specialties to help bring that clinical contents, as well as hospital managers, regulators, and purchasers for innovation as well. And there's also community membership. So we love people to get involved with us and suggest problems that the data could be looked at. So what have we done so far? Well, actually, this slide is out of date now, and we've supported well over 50 projects since we opened in September 2020. Opening during a pandemic is always good fun, but we thought it was really important to have that data access there for the pandemic. We've shared data now with over 180 academic researchers from across the country. We share COVID data with SAGE. We were able to build things like dashboards that were updated in real time to show where COVID admissions were coming to regionally and also where they came from, helping to identify outbreaks prior to community testing. We've also been able to provide evidence to a number of guidelines and regulatory bodies working with researchers. And I wanted to finish with a slide that really discussed the kind of impact that this data can have. So I say slide, I've got a couple of slides just to talk about the kind of projects that we've been able to support. So I'm really happy to talk about the COVID activity, but as I hope we're coming to a point where we can focus on the other aspects of healthcare that are needed, as well as COVID, I wanted to start with some non-COVID examples. So our data has been used to build a number of algorithms that have been embedded into healthcare. The first was one that looked at safer prescribing, and we have a number of clinical decision support tools that have helped with prescribing in highly pressurized environments like the emergency department and acute medical units. One example is data being used to help algorithms for complex prescribing regimes, such as N-acetylcysteine used in paracetamol overdoses. A standard treatment regime is 3 different bags containing 3 different doses of the drug over 3 different time courses in 3 different volumes of fluid. And that tends to cause mistakes, and over 50% of those prescription regimes have mistakes in them. With an algorithm, we've been able to reduce that to 0 in the 4 hospitals that's being trialed at the moment. We've also been able to look at how acuity alerts, so when people come into hospital unwell and it says how sick they are using a scoring system called NEWS2, how well those are flagged and picked up by clinicians so that activity is focused on those that are the most unwell in systems which flag frequently. And we've also looked at how guidelines have been utilised in hospitals. At the moment, every acute care hospital has to provide information about how many patients have had a risk assessment made on the chances of getting a deep vein thrombosis or a blood clot when they come into hospital. But ticking boxes on a risk assessment isn't the same as prescribing the right drug, which should be the end activity of that risk assessment. And we were able to show that there was a disconnect between people doing the risk assessment and prescribing, between 95% compliance with the risk assessment, converted to 70% compliance with prescribing, and through automated decision support tools with strong clinician prompts, we've been able to increase that to over 95%. So that's helped safer prescribing in our group. We've also helped the academic community at a time when funding can be difficult and when it's difficult to continue with research. So we've been able to help other researchers secure over £14 million of grant funding from a number of prestigious funding bodies. We've supported academic research across the breadth of the UK, including a number of high priority multi-morbid based projects. But I wanted to finish to say that not every data request ends with a yes. So although we've had now over 50 data requests coming through, a number have been declined. Some data has been shared, others we've shared a little bit less than people have asked for because we know the types of information that's needed. Sometimes it's been a working process to build towards the data sharing that people needed, although generally we can turn around requests in approximately about a month from the data request coming in to data being shared. And I'll finish there. Thank you.
Great, thanks, Liz. Really interesting to see the example of data and digital technology being used to support COVID response, but also the potential it has to support recovery. So I think in the interest of time, we'll move on to the panel discussion now. So Emma and Janet, if you want to maybe come back on camera. So I've got an opening question, then I'll try and take as many questions from the audience as possible. So I want to start with you, Emma, with a question that the others will be able to come in on as well, which is and maybe a chance for you to pick up on some of those questions from the chat around RCTs and the role of ethics and health inequalities. So I just wanted to ask you what in your experience, some of the main challenges you found are you faced in evaluating the AI innovations that you're funding through the AI pool.
Yeah, sure, Josh. So we've actually done a piece of work over last year to essentially conduct research with our evaluation partners that we have commissioned to do these independent evaluations of the phase 4 technologies. And we've isolated 5 different challenges, as well as isolated some of the approaches that they're taking to try and overcome those challenges. And we're planning to publish a document on this in springtime this year. So I won't go into detail about those 5 challenges, but I'll just speak to the one around randomized controlled trials. So one of the challenges that we've identified is that although there's the ambition to use as robust methodologies to evaluate these technologies as possible, i.e. an interventional randomized controlled trial design, often with the AI technologies and the phase 4 technologies specifically, that's not feasible. It's often because these technologies are often sort of plugged in at the back end within hospitals, it's often not feasible to randomize at patient level. And because of variation between sites in terms of IT systems as well as clinical practice, it's often not feasible to randomize at site level either, because all of the sites are so different. So you wouldn't be able to have similar sites in your, control arm and your experimental arm. And then finally, because these technologies are mostly trying to demonstrate non-inferiority versus current standard of care, and rather than demonstrating superiority, actually a randomized controlled trial may not be the most appropriate design. And you would need quite large sample numbers to adequately power it for that, to see the difference in that, or to prove non-inferiority. Most of our phase 4 evaluations are quasi-experimental pre-post deployment comparisons. But one of the things that our evaluators try and do to understand some of those confounders and biases is to include a triangulation and comparison with synthetic controls. So they try and identify similar sites that aren't deploying the technology in order to try and control for those seasonal changes and across time, and draw conclusions about what effects are coming from the technology versus what effects are just happening anyway within the sites. So that I hope accounts for that question around randomized controlled trials, and I'll hand back to you now, Josh.
Thanks, Emma. Very comprehensive answer. And Janet, I wondered if maybe I could come to you next on the issue of trials. So I think the next step for Project Breathe is to take forward a fuller clinical trial of the tool you've developed in the algorithm. Is there anything you'd like to say to add to Emma's response around how you're going about that, and particular challenges for this kind of digital health technology when you're going forward to a trial?
Yes. So the clinical trial has been set up so that we have a year's lead-in to make sure that we can get the algorithm over into a form that is useful to people with CF. The algorithm as it currently stands is a research tool, and we need to make it accessible through the app. We've got a very extensive user experience, user engagement to help us design the trial, and also to make sure that the way the data is presented to the individual is clear, intuitive, and acceptable to people with CF. Our aim is to take people who are currently part of Project Breathe and to randomize them into 2 groups. One group would continue to receive the data as they currently receive it. The other group would receive their Breathe score, which is the integrated algorithm output data. An important step for us is to establish what is the minimum data requirement to provide a decent algorithm score. And again, we're working on that ahead of time in this year that's leading up to the trial, because the quality of the algorithm is only dependent upon the data that's input. And we are going to create a traffic light system, which would be green, everything is fine, amber, things are not going so well, review your care plan, and red, basically contact the clinic. But there will be a 4th color, which would be grey, which is we have insufficient data to provide a confident algorithm. So we're trying to keep it as safe as we can. The data coming out of it, it's basically patient empowerment. So we want to know whether it's useful or not. That's our primary endpoint. We're going to, but other things would be quite interesting to see if people, when they move into the amber region, come out of amber quicker, i.e. they recognise that things are not quite right, and the readings confirm that, and they potentially do more chest physio, or they contact GPs or whatever. So the length of time that people spend in amber and the number of people who progress from amber to red would be quite important between the two groups.
Great. Thanks, Janet. And Liz, if I come to you now, I don't know if you have anything to add on the challenges of evaluating these kind of digital technologies and the RCT question. It'd be interesting to hear from you if you do.
Yeah, so I mean, I think it is challenging to make sure that the technologies that we're introducing have been robustly evaluated. And the evaluation process is an assessment of how representative the data is and the patients are that are being brought in to that evaluation. We know that if the data itself is quite narrow, the algorithms that might be generated might only suit a smaller proportion of the population. So something that Pioneer and I personally am really passionate about is if we want to use AI and trials of AI to address health inequalities, which is hugely important, and help with the COVID recovery, which is hugely important, we need to make sure that the data we're generating represents all of our communities. And so something that we embed in Pioneer is an assessment of how representative the data we're sharing is with the generic population, so that we know algorithms that are generated fit that. And this has been a problem in all clinical trials, right? Not just AI clinical trials. If you look at the majority of studies in my own area, they tend to focus on a very select group that go through them. So really important is to use the ability to embed these in real life clinical trials, is that representativeness.
Great, thanks very much, Liz. And building on this topic, actually, there's a question from an audience member about implementation, which I think is relevant. So taking when you have an AI or digital health intervention where you've conducted an evaluation, you've got good evidence to show that it works, it's safe, it's effective, it's maybe cost effective. What challenges do you anticipate or have you experienced in trying to implement these kind of innovations in practice? I don't know who would like to come in first on that, but maybe Liz. Yep, great.
Yeah. So, I mean, I think the thing to recognise in the sphere where I work, which is in hospital medicine, is that for AI to work, it has to be written in a way where it can be deployed across different systems. There isn't one thing as one electronic health record or one electronic health system across the NHS. There are a number of different services, and there's also huge differences in the digital maturity of hospitals. So some will be digitally able, but not digitally mature. Some hospitals have large informatics departments that can embed and monitor new technologies. Some really don't. And so when a piece of technology is designed, it needs to have that end user environment in mind from the start. And things will only actually change practice and make a difference across the breadth of the UK and wider if systems are deployed, which then will be compatible generically across the board and not written just to suit a certain group of users. So something that we're looking at UHB, where I work, which has had its own electronic health system since 1999 now, a home-built one, the only NHS-built electronic health system for the NHS, is that because we have a huge understanding of that, we've been able to work with other systems such as Epic, Cerner, a homegrown system in Leeds, to make sure that any technologies can be deployed across different settings. And that, I think, is hugely important and a hurdle that I don't think we've got cracked yet.
Great, thanks. And Emma, is there anything coming out of the AI award in terms of the real world evaluations that you learning about implementation that you'd like to share?
Yeah, definitely. The piece about interoperability that Liz has spoken about is key. I think that's why the most advanced AI technologies are often imaging technologies that analyze images, because the sort of systems are relatively, particularly in radiology, are relatively standardized across hospitals. But some of the other implementation challenges that we have seen are around, because there's no agreed standards as to the level of evidence that is required for the adoption of these technologies. Adopting sites are often not sure whether technologies have achieved a good enough bar in terms of that evidence generation to warrant their adoption. This is a recognized issue, and it's why NICE are currently reviewing their evidence standards framework for digital health technologies to make sure that it is fit for purpose in relation to AI technologies, so that they can provide that guidance as to what should be looked for. I think the other key issue is really around information governance and data sharing, and often there's a bit of reluctance from adopting sites and sort of caution around signing contracts with AI vendors if there's a lack of confidence in how that data will be shared and used, and questions around, will the data be used just for service provision, or will it be used for ongoing sort of research and development of the algorithm? And then if it is used for that, should there be a share of the IP that is taken by the site that sort of owns the data? So there's quite a lot of questions around data sharing, best practice, and sort of commercial models for contracting with these technology companies. But again, that I know that the Centre for Improving Data Collaboration within NHSX are looking at all of those issues and hoping to provide guidance to the system around those things. So,
great, thanks. And Janet, is there anything you'd like to add about the challenges of implementing, from your experience of actually deploying or testing an algorithm-based tool?
Yeah. So very much so. We've bypassed a lot of the issues that are being raised. We are very much patient focused. I used to work in the Cystic Fibrosis Trust, and we're very much patient focused, and we see this as a tool for people with CF. The app and the mobile phone data all lies outside the NHS informatics system. We also have some very clear rules that we're using. So our first rule is very much that the patient owns the data and only shares that data if they wish to. The second is that this is a very, very, very fast moving field, and devices are coming up, new devices are coming up all the time. And so we wanted to make sure that we were uncoupled from any one particular device manufacturer, so that we could make sure that as new devices developed, we could plug them into the system better. The algorithm will only improve with the improvement in the data acquisition, and we don't want to do anything to stop that from happening. So we're a slightly different angle.
Great, thanks, Janet. And I think I'm afraid that that's probably the end of our panel discussion. Otherwise, I'll get in trouble for holding up the next session. So apologies to our audience for not being able to get through all the really great questions that you've asked. I think some are very specific kind of clarification questions, and hopefully they'll be able to be answered by some of the information available on the websites for each of the projects we've talked about today. But just like to say thanks very much to Janet, Liz and Emma for taking the time to join us this morning and talk to us about their work and to answer some questions. And to hand over to now to Stephen Wyatt, who's Head of Research and Policy at the Strategy Unit, who'll be chairing the next session focusing on evaluation of health inequalities during the recovery. Thanks again.
Thanks, Joss. Good morning and welcome to this breakout session where we'll be talking about the role of evaluation in addressing health inequalities, with a particular focus on the NHS Recovery Programme and on digital innovations. My name is Stephen Wyatt. I'm Head of Research Policy at the Strategy Unit, and I'll be introducing this topic briefly before we move into breakout rooms to discuss the issue in more detail. So at the heart of most evaluations are attempts to assess whether or how programmes or interventions are effective. Do they deliver benefits, and if so, how and under what circumstances? It's much less common to see evaluations that assess whether benefits that accrue are fairly distributed. And this second dimension is not just some nice to have, it's of critical importance. A key part of the NHS Recovery Programme is tackling the growing waiting list problem. I'd like to remind you what happened the last time there was a prolonged and concerted effort to increase elective activity and reduce elective waiting times. For about 10 years from the early 2000s, the government introduced several policy initiatives that address this issue: increased funding, contractual incentives for providers, patient choice, NHS funded access to private hospital care, and many others. Between 2005 and 2018, rates of elective admissions increased by about 35%, and waiting times also reduced substantially, at least until the early part of the last decade. But who saw the greatest benefits from these changes? Whilst people living in the most deprived and most affluent areas saw rates of elective admissions increase by more than 40%, people living in the most deprived areas saw rates increase by only 20%. So whilst everyone saw benefits, those benefits did not fall evenly. And incidentally, these differences cannot be explained with reference to the demographic characteristics of the two groups. This is the norm. Whenever we change our healthcare system or add complexity to it, we should expect the benefits to fall disproportionately to those with the most favourable outcomes at baseline. This will happen again as part of the NHS recovery process, unless we put specific mitigations in place. I will only know if these have been successful if we measure it. Part of the reason why the issue of distributional fairness hasn't often featured in our evaluations is because of the relative priority of that issue, at least in the past. But I do see that changing, driven at least in part by from within the evaluation community. But I suspect that there are some other legitimate methodological concerns that have also played a part in holding back this issue. In a traditional quantitative evaluation, our sample size calculations are based on estimating an average levels of effectiveness across a population. When we want to measure differences in effectiveness between socioeconomic groups, for example, then we may need to make 5 estimates, one for each quintile of deprivation. And of course, deprivation is only one of the possible dimensions of inequality. We might want to compare outcomes for men and women, people from different ethnic groups. And each time we want to estimate a quantity for a new subgroup, we must either increase our sample sizes or, I guess, reduce our precision of our estimates. And if we want to incorporate aspects of intersectionality, as we're increasingly being urged to do, to assess, for example, whether the experiences of belonging to a particular ethnic group are felt differently for men and women, then sample size calculations can get out of hand quite quickly. So we're going to move into breakout groups in a second to explore these issues in more detail. You'll be moved into a breakout group automatically. Each group will have about 15 participants. There'll be a moderator guiding you through the conversation and collecting your comments. Arne Walters will be summarising your views in his closing remarks at the end of the session. These are the 2 key questions I'd like you to consider. First of all, who's responsible for ensuring that health inequalities is a core perspective in health service evaluations? What is the role of commissioners and what is the role of evaluators? And secondly, how can we overcome some of the practical or methodological challenges of measuring distributional fairness in our evaluations? Now, I know there'll be people in the conference today that will have been involved in evaluations that have successfully incorporated aspects of distributional fairness into their evaluations. So we want to hear particularly from you, how did this come about and how did you respond to the challenges? So we're going to move into breakout groups shortly, and there'll be about 20-25 minutes for discussion. And after that, at 11 o'clock, there'll be a short comfort break until 11:10. Thank you.